Hello everyone. Welcome to another Rafael Medina subspecialty virtual morning report. Today we have two very special physicians from the University of Tennessee Health Science Center, and we're very excited for today's case. We have with us Dr. Poulos and Dr. Jackson. Uh, Dr. Poulos, would you mind introducing yourself, telling us why people should go into primary care, and what are you grateful for this week?
Sure, absolutely. My name is VN Poulos. I'm originally from Nashville, Tennessee, and now here at the University of Tennessee as a fourth year chief. I'm the ambulatory chief here, and super excited to be with y'all tonight. So thanks for having me. Primary care, honestly, has become a huge part of my life, and probably was sooner than I thought. But my main kind of reasons for going into it were obviously just the continuity of care and relationships that I've had with patients, but even more so kind of working with them to reach their goals and help them trust kind of the system and diagnoses that we're going through. And I can't say that there was a more rewarding experience for me as a physician, and being able to kind of earn my patients' trust and work with them to treat them and help them feel better really has been a calling for me almost more than just a career. So I highly recommend it. And can't thank Dr. Jackson, who I'm sure is going to introduce himself here in a second. And I am going to say that I'm grateful for him because he was my mentor the last 4 years and really helped me realize my passions in primary care. So I'll hand it back over to you all.
I love that message. Dr. Jackson, I'll hand it over to you if you can introduce yourself. And I heard you have a lot of passions in med ed and EBM, and I would love to hear how it's like to pursue these passions, and what do you recommend to trainees that watching?
Sure. No, so it's a pleasure to be on. I'm Chris Jackson. I am a primary care internal medicine physician at the University of Tennessee Health Science Center at Regional One Health, our county hospital. I'm also an assistant dean in the Office of Student Affairs for the College of Medicine and associate program director in our medicine residency program. And recently took on a title of president of the Southern Medical Association. And so for me, when people ask me why med ed and what I find so interesting about it is I learned very quickly that if I wanted to touch the lives of one or two or three patients, I could do things in direct patient care. And then if I wanted to touch the lives of more patients, I could get involved in research. My interest in EBM was in how guidelines and how evidence-based practice is crafted depending upon where you live and where you work. But more importantly, if I wanted to make an impact on multiple generations of patients, the only way I knew how to do that well was to teach. And so getting a chance to teach students and residents and fellows even how we take care of people in the clinic, and how a lot of good medicine also happens in the clinic as well, became kind of a driving passion for me. I would say for me, education and mentorship is kind of my antidote to burnout. While I love being a primary care doctor, it can be very challenging at times. Sometimes our patients have social circumstances or disease processes where there is not a one pill to fix it, or there's not even like one way to manage it. And that can create stress for both that patient as well as for the clinician taking care of them. But for me, having kind of education, mentorship be other things that come alongside my interest in primary care kind of again gives me that balance in my professional career that I enjoy. To my friend Reza Manesh, who's talked about finding joy in medicine. I think it's all about kind of finding those things both within patient care and maybe sometimes outside of patient care that fill your cup, so that you can continue to do the things that you enjoy. So um, love EBM. My one plug is that if you could go to one course, the Duke Teaching and Leading Evidence-Based Medicine course is probably one of the best you can find. That's where I discovered my love of EBM, and happy to talk to anybody about it. But I'm so delighted to be here today, and hopefully we'll have some fun.
Yeah, congratulations on being elected president. I can definitely see why you're elected president. You seem like a role model to many, many people, and I'm sure you're a role model to many people watching today.
Yeah, it's very kind.
Noah, if you're ready, we can share the whiteboard and we can start with the case with the first aliquot.
All right. Okay, we'll go ahead and get started. So we have our chief complaint today. It's a 33-year-old male. He's presenting with unilateral paresthesias.
Okay.
Yeah. And I'll go ahead and start just kind of filling in some of his HPI too. So this has been going on for 15 days, he says. Kind of started with right-sided weakness, numbness. Family kind of reported a facial droop that they noticed on that right side as well. And then sometimes even issues with word finding or dysarthria or just kind of slurred speech really is what they described. These symptoms, since they started, were pretty constant in nature. Prior to it all starting, the only event that was kind of notable is that he felt a little sick, like flu-like illness, congestion, sore throat, maybe chills. And then really the slurred speech kind of happened first, and then the paresthesias and the weakness. Otherwise, he felt like some of his strength had been regained, but his family still felt he had some difficulty with the word finding specifically. And then he also reported just feeling subjectively fatigued and febrile at times in those 2 weeks as well.
Okay.
Thank you for that. And Dr. Jackson, I see we have a broad constellation of symptoms, including weakness, droop, dysarthria, word finding difficulty, and flu-like symptoms. How are you categorizing those symptoms in your brain, and how are you approaching this broad presentation?
Yeah, so thinking about, I'm going to put this in general like a neurological bucket. We have a patient coming in with, unilateral paresthesias affecting right side of the body. Part of the challenge for me is, acute neurological things in clinic. Of course, I'd worry about things such as, stroke. Certainly worry about things like complex TIA, migraine. In the right clinical context, would also worry about infectious processes. I've seen tick paralyses that could look like this as well. Certainly, the flu-like illness is kind of pointing me towards kind of an infectious etiology leading to some sort of, sensory neuropathic process is the first thing that comes to my mind. Stroke to me would be a little less likely just given the time course and the tempo of symptoms. Certainly, I would want to hear if he had a previous history of neurological injury, maybe involving, MCA, particularly since we're talking word finding difficulty and maybe things going on in the upper extremity, I'm guessing. These are all things that, initially come to my mind. In general, in the clinic and even in the hospital, I try to focus on the symptom that has the most limited differential. So while weakness is, a symptom in this case, I don't tend to focus on it as much just simply because weakness has such a broad differential from a medication-related side effect all the way to acute neurological injury from stroke, seizure, et cetera, all the way to just kind of a general asthenia. I'm weak, like even though on physical exam, I actually have preserved strength, and maybe that's just in the setting of acute illness. And so I would kind of put weakness a little bit off to the side and really focus on these unilateral paresthesias first. The other thing for me, that comes, to my mind is the facial droop, and so certainly in the right clinical context, that also makes me think of viral things. You see kind of like a Bell's palsy, and I'd be curious, like, is it involving the entirety of the forehead and face, or is it just involving the lower half of the face? Because typically the forehead gets dual innervation, and so as a result of that, if the patient it has no wrinkles going all the way down the face, then that would make me worry more that it's a lower motor neuron problem versus if the forehead could wrinkle and then the rest of the face could not, then that would make me think of some sort of upper motor neuron deficit or things. So.
Yeah, Dr. Poulos, back to you for aliquot 2.
Yeah. So basically, otherwise, in terms of his ROS, the only other thing that his family had added was maybe that he had mentioned some headaches and occasional visual changes. Relating to his history, Dr. Jackson, he doesn't have any history of stroke and really doesn't have any chronic medical conditions. He actually really wasn't followed by a primary care physician, didn't really seek out any care until this kind of more acute event. Med-wise, he really takes nothing prescribed. He just took an occasional PRN Tylenol or acetaminophen just when he was feeling subjectively, he just had the headaches or the fevers. In terms of his family history, he did have a brother with stroke at the age of 35, he told us. And social history, he immigrated about 8 months prior to his presentation from Honduras. He had a past use of cocaine and marijuana, but hadn't used them in about a year at the time. And then currently only had one female partner, and in the last year. Otherwise, really no other health-related behaviors to add, no allergies or anything like that.
Dr. Jackson, bringing it back to you. What stands out to you from this history, or is there any particular part of this history you're extracting? And is there any particular tips and tricks you have for trainees taking history in clinic?
Yeah, no. So, in the QI literature, there's this thing called like the 5 whys, where basically if you want to get down to what is the most likely foundation of the problem, you want to be able to kind of ask why till you get down there. And so I would say really nailing down the why here is important. In terms of other things, to help with history taking, clarifying what symptoms mean to patients. So I'll take the symptom of fatigue. Fatigue could mean everything to me from muscle weakness. I've seen for some patients it means short of breath. I've seen for some patients it actually means kind of more of a sleep disturbance. I feel tired. But in general, people view fatigue in different ways. And so I think making sure that what your conception of the patient's symptom is and what their conception of it is similar is important here. When I, kind of look at the additional history that I'm given, a few things that point out to me as a brother with a stroke at age 35. That's very young to have a stroke. So I start thinking of, is there something, congenital? Is there like a familial hypercholesterolemia that could have led to that? When I think of the travel history, the social history that's given, when I think of, immigrated from Honduras, is there infectious processes or things that I should keep on my differential? I always think of like, neurocystosarcosis as kind of one associated with kind of like travel history and things like that. And so I'm keeping that in mind. Certainly in terms of, the sexual history, nothing is jumping off immediately in my mind in terms of processes that would, cause this kind of unilateral paresthesias. I would say with the slurred speech, I would be curious, like, is this something the patient has noticed versus the family has noticed? Because that can kind of give me some sense of, is this a very mild deficit? Is it moderate? Is it, a severe deficit? That would be, something else, I'd want to know from history. The other thing that is, coming to, my mind is that this is a subacute process, I would say. It's not acute. And so if this is infectious, that tends to make me think along more of a viral or fungal pathway. Typically, more bacterial processes hit you pretty quickly. And then when they hit you like that, usually you would expect, again, probably a pretty prompt resolution of symptoms. So I'm still kind of in an infectious / infectious triggering some sort of autoimmune process. That is where my mind goes. I'm thinking less likely, stroke or something like that. Just even though I have the history with the brother having this, just again, the tempo of illness, doesn't make sense for this to be an acute stroke process. So still a lot of unanswered questions, but if I had to put my money somewhere, this is an infectious or autoimmune process. And there are some infectious or autoimmune things that come to my mind. Again, tick-borne illnesses are starting to ring up there true for me. There's also things like acute disseminated encephalomyelitis and acute necrotizing hemorrhagic encephalitis, but I need to hear more about what is his mental status with those and actually document whether or not he has any motor deficits, on exam. I would also say to my remembrance, acute disseminated encephalomyelitis and ANHE are usually more so seen in kids. Another thing that I would add in there is I'd be curious this patient's immunization history, because there are also some immunization histories or not that can be associated with kind of the encephalitic-like picture too. So.
Yeah, thank you so much. These are very good points with like the broad differential and the tempo. Dr. Poulos, back to you.
Yeah, just to fill in a couple of things that you mentioned, Dr. Jackson, I unfortunately don't have a recent immunization history for the patient. No evidence that he had gotten any recent immunizations. He did notice the slurred speech himself, and family also did notice it. So it was a two-way street. And then in terms of his sexual history, he did have one consistent partner at that time, but had several partners in the past with unprotected intercourse. So just to kind of fill in a little bit of that history. In terms of his physical exam, though, that was really all the kind of other information I had. Vitals were stable. He was afebrile at 37.4. His heart rate was 91. His blood pressure was 111/72. And his respiratory rate was at 19. And he was saturating at above 95% on room air, no distress. He was pretty lethargic even on exam, even just like talking for a while, especially because this was a patient that had a language barrier. He kind of was even tiring out kind of throughout that conversation. In terms of his HENT exam, he had equal and reactive pupils, extraocular movements were intact. He did have a right-sided facial droop that we could appreciate, but his sensation was intact on his face bilaterally, tongue was midline, and at least at that time, I didn't appreciate any slurred speech or dysarthria. His CV exam and his pulmonary exams were all normal, no appreciated murmurs or anything like that, clear to auscultation bilaterally. His abdominal exam was also normal, no tenderness to palpation, no distension. Extremities visually were normal and pulses were all intact. No pronator drifts, but he did have weakness that was mostly appreciated in the right lower extremity, about 4 out of 5. The remainder of the extremities were 5 out of 5 in terms of strength. His sensation was intact as well in all of his extremities. Patellar reflexes were 2+ bilaterally, and his finger to nose and heel to shin were also intact. Let me make sure there's no other exam findings. Skin was also kind of appropriate, no obvious lesions or rashes there. That's pretty much it, I think, for his exam.
Yeah, I think my question in general is, how does like the objective weakness affect your thought process? And if you saw this patient, how would you decide their dispo, or what helps you decide their disposition and what to do next?
I love this question. And so I think this is a case where your level of alarm will go up, I think, one, with the fact that there is this objective weakness in a 33-year-old that, has no other reasons, at least before this, to have weakness on exam where they're 4 out of 5 or 4+ out of 5 instead of 5 out of 5 in all extremities, and it's focal. Kind of similar to the moniker, if you get one abnormal EKG, you should go back and look and see like what the previous EKG was. If this patient had been seen in the system before, I'd want to go back and see what the neuro exam or thing looked like for this patient before if they had one. I will say with the weakness and the patellar and other reflexes essentially being fine, makes me go down a pathway of thinking whatever's going on is affecting lower motor neuron probably more than upper motor neuron, because I would expect like clonus and other findings. I will say in terms of the sensation intact, so this seems like it's mostly a pure motor problem. So whatever neuropathy like picture this would be like a motor neuropathy, not like a sensory motor or mixed process. I don't see that this is going on in kind of like an ascending pattern or anything like that. So, you think of like acute inflammatory demyelinating polyneuropathy or like a Guillain-Barré, it doesn't fit kind of that picture to me, which, could be a worry when you initially hear like the flu-like illness and now I'm having paresthesias and weakness and things of that nature. To the question about, disposition here, I think there's a lot to think about. So one, to what extent do we to what extent do we feel we have ruled out the things that can, immediately kill or harm the patient? So, to what extent do we feel it's not a stroke, it's not a bleed, it's not an acute clot or thrombus, so that's one thing that would affect my disposition. Another thing that would affect my disposition is to what extent do I believe this patient is going to be able to navigate the healthcare system and get to neurology. I know in my system, like this patient could get lost through the cracks very easily. And so if I were worried about that, that might push me a little bit further in terms of, hey, maybe we should not disposition this patient home if we don't have kind of a better sense of what's going on with the patient. I think also, and maybe this is a bit of my own bias, but, I don't have a ton of 33-year-olds that would voluntarily come to the clinic and say that, they're having weakness, dysarthria and things. And so my bias being that, for a 33-year-old to come in to say this, like it is worrisome to me. And it would be enough where I would want to, make sure. The other thing I'm curious about here, and this was just something I thought about as I was looking through the neuro exam, is I'd be curious the cranial nerve exam, because right now, I'm thinking motor, but, are there bulbar signs and symptoms? We think of like dysarthria, dysphonia, all those things, but would be curious if there are any cranial nerve abnormalities. But yeah, those are things that would impact it. And I guess another thing that would impact it here is what is my level of risk or concern for meningitis too. That would be another thing that's up there. And even though the patient is afebrile, if this is more a subacute process, they don't necessarily have to have, rip-roaring fever, tachycardia like I would expect with, acute bacterial meningitis. If this were like a TB or cryptococcal or a otherwise fungal meningitis, like they could definitely not have fever and things like that. So those are some of my thoughts.
Thank you. I love the pearls about worrying about life-threatening things and things that are practical, like time to get to follow up with a specialist and time to get the workup done. And Dr. Poulos, can't wait to hear more.
Yeah. Those were some great thoughts, Dr. Jackson. At least on our exam, we did not see any prominent cranial nerve deficits. He didn't have any difficulty with like his trigeminal or his abducens, any of his eye movements. His facial expressions were appropriate. I will admit, I don't know that we fully did every single cranial nerve exam, but he didn't have any like difficulty with gagging or swallowing or any of those things. So overall, his cranial nerve exam was fairly normal.
And sorry, one thing I'll add, I appreciate you saying that, Dr. Poulos. So for me, I've never tested cranial nerve 1 except when I was a third-year medical student. I probably wouldn't know how to do it now if somebody asked me. But the ones I care about are the ones that are around like cranial nerve 7. So to me, cranial nerves kind of 7 through 10 kind of sit in the back part of the brain here. And so those are the ones that I care about the most, because it's unlikely for a disease to hit just one of those nerves. Like it probably is going to hit multiple of them at the same time. And so the lack of gag issues, the no significant dysarthria, all these things is frankly a little reassuring to me in that way.
Yeah, thank you. So just kind of notably, since we talked a little about Dispo, we did actually end up deciding to send this patient down to the ED, and Dr. Jackson kind of artfully pointed out a couple reasons why. Part of that was really just because we felt like this patient would fall through the cracks and would not receive timely care with this sort of subacute presentation. And just the degree of kind of lethargy in a young person that we were seeing with some of these neuro deficits made us think that maybe this needs to be a little more expedited. So we did get kind of sooner labs and imaging, and we can talk about those now. In terms of his CBC, he had a white count of 3.8. His H&H was 12.9 and 37, and he had platelets of 159. His ANC was 2,500, and his MCV was 88.2. In terms of his chemistries, he had a sodium of 135, potassium of 3.7, bicarb was 28, his creatinine was 0.8. Glucose was pretty normal at 121. All of his liver enzymes, were normal. So AST, ALT, his alk phos, and T-bili were all normal. His calcium was 7.6. He had a lactate of 0.5. His procal was negative. And then he also had a UA that was within normal limits, and a Hep B and C panel and RPR, which were negative. Those were kind of the most notable labs that we had initially gotten. He did have a CT head that showed a left parietal subacute MCA territory infarct and no hemorrhage. Shortly after we got that CT, some more of his labs came back, and we found out that he was positive for HIV, both the antigen and antibody confirmed. And he had a viral load of about 1.7 million, roughly, that was untreated and he was unaware of. And his CD4 count was 65 at the time.
Okay, Jackson, I know this is a lot, so I'm just going to leave you to react to it. And what are your initial thoughts to this initial labs and imaging?
Yeah, well, that took a turn that I was not expecting. But a lot of things actually come to my mind now. And so when I was first hearing about the white count, there, depending upon where your lab is, there's kind of like this leukopenia. The platelet counts being above like 150 was a little bit reassuring to me that we're probably not dealing with something like tick-borne, because usually tick-borne stuff, like RMSF things, you usually see kind of like a bicytopenia, white count's down, platelet count is down. The chemistries and everything look, pretty unremarkable. The HIV being, positive, where we are in Memphis, Tennessee, we have very high rates of HIV infection. And so even if this patient didn't have that, we would be screening for it, and just a primary care, throw in, USPSTF grade A recommendation to screen all 15 to 65 usually, or 13 to 65, I believe it is, for HIV. And then for Hep B and Hep C, it's Hep B, CDC says screen all adults 18 and older at least once with a triple panel test, and Hep C 18 to 79. So the HIV being positive now really shifts me to like HIV plus focal neurological issues. And so for me, I start thinking about things like toxoplasmosis. If there's like ring enhancing lesions, I think about progressive multifocal leukoencephalopathy. Can also see that with like, JC virus. Certainly HIV, you can also see just like, brain abscess and things associated with that. The left parietal subacute infarct, I'm trying to convince myself whether or not that is a innocent bystander or a culprit, and I'm not sure which of those it falls into yet. Certainly, if it's on CT, it's at least had to be there for somewhere between 3 to 7 days. And so I probably would get more data from getting like an MRI and seeing if there's diffusion weighted changes around that same area to say, okay, this is actually related to the infarct that is there. With the CD4 being less than 65, of course, again, toxo would be a big thing that comes to my mind. It's not low enough yet where you consider things like MAC, and MAC would be abnormal to go to the brain. MAC usually is going to be more lung, more GI system. So I don't think that is contributing. For me personally, probably the biggest things I want to know now are what's on the MRI to make sure it's not just that left parietal subacute infarct, but that there might be something else. I would be curious if the patient had been tested recently for HIV or so in the recent past. That would be an important a question to me. And then just because I've seen a lot of co-infection in my patients, we talked about HIV, Hep B, RPR, but I'd be curious about Hep C here too, just because we have a lot of HIV, Hep C co-infection in our area. And then, why does a 33-year-old have a left parietal subacute infarct? And so it's hard for me still not to put on my primary care hat and think like we need to work up that stroke with some sort of like TTE telemetry. Can I get a lipid panel? Like, is there features, concerning for familial hypercholesterolemia? Because, again, I still have this, patient, having a family member's brother that had a stroke, before. So those are a few thoughts, but for sure, when I was in the ER as a resident, we said the mission is disposition, and so this patient's disposition is that they're not leaving. They're probably going to find their way inside the hospital.
Yeah, I love the primary care energy of throwing the USPSTF guidelines randomly in the middle of the conversation. I love that. Dr. Put us back to you.
You always have to give some credits to the USPSTF, Dr. Jackson. So I appreciate that.
Absolutely.
But yeah, so I think you're absolutely right, Dr. Jackson. The mission is disposition, and he went from the clinic to the ED and was admitted. And he waited patiently for his MRI that he got several hours later. So we do have those results. He had basically a multiple foci with hyperintensity and peripheral enhancement along the left inferior frontal gyrus and the left superior temporal gyrus. So he had two different lesions. One of them, the larger lesion, was about 2.5 by 1.4 by 2 centimeters, so about 2.5 centimeters in size, and the other was around 1.5 centimeters in size. Both had increased enhancement along the lateral aspects of the lesions, and there was no other kind of signs of intracranial hemorrhage, midline shift, or really any infarct. So what we thought was really that we might have a kind of a read that was misrepresented in his CT. But that was our kind of next step. So I'll let you go on from there.
All right, so multiple foci, hyperintensity, peripheral enhancement left. For me, the biggest thing that's coming to my mind is toxoplasmosis. Like when I think ring enhancing lesions, HIV, CD4 count less than 100, that's the first thing that comes to my mind. Progressive multifocal leukoencephalopathy also comes to mind, but not as high as toxo. Sometimes we see primary CNS lymphoma put there, but usually that's usually one singular lesion, not necessarily like multiple foci, as in this particular patient. For me, ideally getting this patient on some sort of antiretroviral therapy, probably with Biktarvy, and then patient probably also needs treatment for toxoplasmosis. I would also imagine that the patient, would be seen by our wonderful ID colleagues who would, help us with, getting definitive testing. My guess is patient's going to need some like serum IgM testing or something like that to confirm whether or not this is, toxoplasmosis. But I believe, if I'm right, that it's toxo, that the patient should get better with therapy, mainly getting HIV under control and then also treating the toxo. I still put in there neurocysticercosis. I think that is definitely still on my differential, and won't exclude it just yet. In terms of I was weighing back and forth until I got the MRI whether or not this patient needed an LP. And so I'm still wrestling with that question. I'm not excited about it given kind of the multiple foci, hyperintensity, things like that. And so I would probably, defer, LP and hope for either serum or other testing that can kind of give us the diagnosis. But again, my thought process right now is toxo versus PML, versus neurocysticercosis, again, leaning more so toward toxoplasmosis with the HIV history, the multiple ring enhancing lesions, and this kind of subacute disease process.
Yeah, thank you, Dr. Poulos. What did you all do next?
Yeah, so I actually ended up taking care of this patient on the inpatient side as well. We did defer to our colleagues in neuro and neurosurgery about whether or not we would need, an ID, of course, about whether or not we would need an LP, and they did decide to proceed with one. So his final CSF results, he had a white blood cell count of 3, protein was high at 51, glucose was low at 34. And we did get samples for toxo IgM, which was positive, and then EBV IgM was negative in the CSF. So his final diagnosis did kind of end up being toxo, as you were saying. So yeah.
Oh, what an amazing case, and Dr. Jackson, what an amazing discussion. I was wondering, what 2 or 3 teaching points would you extract from this case, Dr. Jackson, for learners to take? But before that, I'm just going to ask Dr. Poulos, how was your experience caring for this patient on the outpatient side and the inpatient side?
Yeah, absolutely. So this was actually, I thought, one of the more rewarding and challenging patients that I got the pleasure of kind of working with and taking care of. With the language barrier and his recent immigration, I think he had a natural kind of fear and distrust of the system, and just fear of, this new 2 really huge new diagnoses that he had gotten. And he actually ended up being treated as well for retinitis and Candida esophagitis. So he had several things going on, and we really as a team had to build rapport with him and his family for them to kind of understand that this wasn't necessary. It was a life-changing diagnosis, but not a life-ending diagnosis. And bridging kind of those barriers between cultures, and also with just a challenging and kind of life-changing diagnosis in general, was really rewarding. And he ended up essentially getting placed in our kind of HIV primary care clinics now. So I don't take care of him regularly because we're fortunate to have that at UT, but he's doing great now. He was fully treated with Bactrim, and is doing well. Now is on antiretroviral therapy. And I think, not only did this kind of teach me multiple things about him and how to kind of best care for patients like him, but also how to really look at subacute presentations in the clinic, like Dr. Jackson mentioned early on. He didn't really have any sometimes what we would call glaring red flags of instability. He was hemodynamically stable. He wasn't febrile. He had been feeling this way for a couple weeks. So I think he really easily could have gotten lost in the cracks of our system if we had sent him home. So yeah, I really, really enjoyed meeting him and taking care of him, and thought he was a great case to share.
Yeah, and that's very inspiring, connecting the patients from the clinic into the inpatient world and then back to like getting their primary care provider. They were lucky to have you as their doctor. And Dr. Jackson, back to you. Any reflections on this case and what do you think trainees should take from it?
Oh man, no, this is a, you know, this is a very, very wild case. And so for me, I think the first thing to take from it is everybody has to adjust their antenna for discomfort. Every primary care doctor I know, we all have a certain level of discomfort with things. My grandmother would just say it just doesn't look right. And so, for me, even though I couldn't tell you this patient had toxoplasmosis, HIV. What I did know is that a 33-year-old lethargic male coming in after a flu-like illness with like slurred speech and paresthesias doesn't fit within anything where I could safely in my mind say like this is just going to resolve at home without any issue and they can follow up and be fine. Um, and so as you go through training, part of what you have to do is be able to figure out kind of where your lens of discomfort is and adjust it so that in this case, you do the right thing and you send the patient to the ER. So I think that's, the first thing. I think the second thing is with symptoms, be curious, not judgmental, sometimes I have seen younger patients and their symptoms brushed off, whether it's, weakness, paresthesias, et cetera. It's kind of sometimes when we can't immediately explain things, we just kind of say, oh, well, it'll be fine. But particularly when you kind of take this patient's symptoms with also these objective findings on exam, a very weak right lower extremities, other extremities fine, right-sided, facial droop, like, even though I couldn't fit it into a neat scheme at first, the scheme that did fit in is that, there is something going on that needs further investigation. And then I think the other thing that I would say is, as much as you can, try to make things harmoniously, come together. I'll be honest, I was really hinging on tick-borne. And I think, that's, because I was thinking paresthesias, maybe some degree of, paralysis. And I had to really watch out for anchoring on that diagnosis. And part of what made me stop anchoring on it was the lack of thrombocytopenia, the lack of liver enzyme elevation that we typically see with tick-borne stuff. And now, I get HIV, I get the CT head showing up for MRI. Okay, now I have enough diagnostic momentum pushing me away from something tick-borne to where now I need to really think, okay, there's something else, going on here. And also, I just put out there, be humble with it. I didn't have the diagnosis at first. I had no clue what case we were discussing. I am a very happy primary care doctor. Do not step into the hospital a ton, but using just a little bit of clinical reasoning, putting things together, asking, is this Occam's razor or Hickham's dictum? In this case, I was going that this is more Occam's razor and I need to be able to put all these things together. I think, can help. But even if I didn't get to the diagnosis, enjoy the journey, towards it. And so whether in this case, talking about subacute meningitis, facial droop, paresthesias, et cetera, thinking about that. And I guess the last thing is time is key. So even though there was a stroke, on imaging, it just didn't fit the tempo of illness. Versus a subacute infectious process did. So that would be my reflections.
Oh, what a wonderful reflection. And I really, really love this case, how you both took us from different places in the hospital and how you foresaw what would happen to the patient and predicted based on like practical reasons, the disposition and the plan for this patient and the focus on the tempo and your clinical gestalt, which was amazing. Thank you both for joining, Dr. Poulos and President Jackson. We're honored to have you both, and thank you for teaching us.
Absolutely, it's our pleasure. And would not have wanted to do it with anybody else besides my awesome mentee over there. So
Thanks so much for having us, and thank you, Dr. Jackson.